sure that we will have all medical colleges, schools in India having departments of family medicine in near future. Uh, uh, we know in Maldives we have a few GPs who are providing good quality services, and few of them are trained in Nepalese medical schools, colleges. So overall, things are positive, but in recent time we all are challenged. So it is opportunity for us to see where we stand in our respective countries and to see how, as family doctors, we can engage, progress. And I always say, not only from the perspective of our own discipline, but in the terms of how we achieve the objectives of the overall of our society and population. So thank you. This is briefly from our region. Sri Lanka has been very strong family doctor system traditionally. It is well placed, and today on Facebook we celebrated the 90th birthday of Professor Leela, and she's one of the senior most faculty in our region. So you see, we have long history of strong family medicine system in Sri Lanka. So overall, we are in the midway of our journey, and we have to cover distance. And given the reforms taking place in terms of the Sustainable Development Goals of 2030 and the universal health coverage, and we have to see how we align ourselves as family doctors, family physicians, primary care practitioners, as team members in advocacy, education, research, and of course, on all possible ways we can do. Thank you.
No, thanks, Raman. And just to share very briefly, and I think before we get into questions, Yandamasana basically would like to say a few words about a project that we support quite strongly. And maybe, Jan, let me just say these few words and lead into what you're going to say, and then it'll be a bit more contextualized. Jan, is that all right? I'll just be a few minutes. Right. So basically, from a sort of from Wonca Africa point of view, I think people know that Wonca Africa has had a quite a long history in Wonca, but it's been very few members, South Africa, Nigeria, for many years. And I think there are some new members that have slowly accumulated over the last decade or two. A lot of it due to work that Yandamasana has done with supporting African colleagues to set up, to have a regular conference, which was a very important thing for us in Wonka Africa, and then to help build up the Prima Famid network, which is now the official academic arm of Wonka Africa, as well as setting up the journal that is the African Journal of Primary Health Care and Family Medicine. So in terms of progress, I think that we're now sitting at around 10 or 11 members, almost three of them just in the last year. And countries like Ghana, Zimbabwe has actually been there quite a long time, but Ghana and Lesotho and Uganda have been pretty recent. And there's a great deal of work being done in those parts of the world, I think, working in difficult terrain. One of the key things that has happened in this term that I think worth sharing is that with the work that Donald Lee did around engaging the WHO, we had an opening where the WHO Afro responded after much pestering to us in terms of bedding down that memorandum between Tedros and Donald Lee with a view to saying, how do we actually work together as organizations? And I think that from that from that collaboration, which grew into the Dr. Tumsime, the sort of head of health systems development in WHO, sort of just after the G regional director, he came to our conference. I think it built up a relationship. We took it out after that by meeting with the joining the RD and meeting with the office at the time. And after that, we set up in our meeting, after our discussions at the Wonka conference as well, we set up what we called Afro-PHC, or the African Forum for Primary Health Care, bringing together the primary health care team leaders who are nurses, clinical officers, associates, and a whole range of others in that space. And that's become a very powerful space for advocacy for us as Wonca Africa, and I think that that is the process that's been unfolding. I think that's basically where we're at right now in sort of big sweeps. There is a lot more detail in the report that I've just circulated, so feel free to go and look at it more closely so that we can understand each other. One of the key things that we've tried to have had a great difficulty in the African setting is the strong dominance of foreign aid and funded programs, which have been forced by funders to be very strongly verticalized and narrow in their scope. And so Jan is going to talk about the 30 by 2030 campaign, which is, a really important thing for Africa, especially because, with the HIV and large programs, these have really hindered our function in primary health care. But let me pass over to Jan to talk about that campaign that's just been published in the WHO Bulletin. I think he's put out the link, so have a look at that to understand what that's about and how you could actually also capitalize on that campaign, spread it around. And I think that we intend to make it very prominent in our discussions in the Afro-PHC as well. So Jan, perhaps you can share a few moments on the campaign, and then we can open up for discussion on the questions we've raised.
Thank you very much for all of you to having time, and hello friends. It's really a pity that we cannot meet in person nowadays. Can I just share the screen, please?
Yes, go ahead.
Because I have a five slides presentation.
All right, give me a second.
Jan. If you allow me to share the screen, my screen with the PowerPoint.
Yep, now you are.
Okay, so now I can share the screen, and let me try to see where I can find this PowerPoint. Do you see the PowerPoint now?
I think not yet.
Not yet?
No.
Okay, I'll try it again.
When you opened it, then it should be available.
Yeah. So the share screen, and then I've got it here. It is on my computer, but...
Have you opened it, Jan?
It's open, yeah, the PowerPoint is open. Right. And I put it now on the full screen.
Somehow can you see you're not seeing it. If you click on the share screen, you should see your PowerPoint showing up. If it's not, then it's then you haven't opened it, I think. Anyway, you can try now again. Yeah.
I can try again. Okay.
Yes, try again. Otherwise, if it doesn't work, we can just talk through it.
Yeah, we can just talk through it. That's not a problem. Let me just try to have.
Okay, it's working.
I will do it quickly. It's already there. Moment, I can do it immediately. So, the 30 by 30 campaign. And let me do. Yes, I think it should show up now. Is that correct?
I think you'll have to try sharing that document if you opened it up. So go back to the share screen and see if you can change it to the presentation. Okay. Yep, now we got it.
We got it, okay.
Yep.
My apologies, thank you very much.
Go for it.
So the 30 by 30 campaign, the 30 by 2030 campaign all reminds us, the people that are not so young, about the 15 by 2015 campaign. Because already in the early 21st century, we just were confronted with the issue that Shabir explained very clearly, that in many places, there is a kind of, disequilibrium between the public resources for supporting primary care on the one hand, and on the other hand, the resources for vertical disease-oriented programs. I think Zambia in 2006 was the most clear example, where the president had a budget of $136 million whilst the PEPFAR amount of money, which is the vertical money for HIV/AIDS, was 150 million US dollar. So there was more money for one disease than to treat all the disease together by the Ministry of Health in that country. And that's absolutely a challenge, because we know that that has a negative impact on the development. And so we came together and we wrote this paper on universal health coverage and primary health care, the 30 by 2030 campaign. And I sent you the link in the WHO bulletin. It's already there in pre-publication. And there were 3 contributors from Africa, Professor Moussa, Professor Bob Mash, and Elsie Kiguli Malwade, who is the president, the Secretary General of the Network Towards Unity for Health. So Africa is absolutely involved in this development. And we described in this article that you see now on screen what the mechanisms are. And what we really saw was that there is a difficulty in increasing the spending in primary care. In most of the low and middle income countries, the share that goes to primary care is rather limited. And there is an issue to strengthen primary care. And in order to do that, on the one hand, you need more resources. But on the other hand, we analyzed the situation and we came to the conclusion that very often the vertical disease-oriented programs are harmful for the development of the local healthcare system. And there's a lot of evidence that points into that direction. So you need a kind of double approach. On the one hand, more resources for primary care, but also try to integrate the vertical disease-oriented programs into the local primary care system. And that's the approach we need. And in 2008, we wrote already in the BMJ on the 8th of March, 2008, this article with also a lot of contributors from Africa, being in those days Kayam Fenyana and Nelson Siwankambo. And I think a lot of you will be familiar with those people. And where we already said, well, we should invest 15% of the vertical disease-oriented budgets towards strengthening local primary care. There was a lot of adhesion for this idea, but in practice, almost nothing happened. And so we were motivated to start again, now making the statement much more clear, that we said, well, we call for major international donors to assign a part of their vertical disease-oriented categorical budgets, increasing to 30% by 2030, to strengthening horizontal primary healthcare systems, so that all diseases can be prevented and people treated in a comprehensive way. We want to put with this into practice the World Health Assembly Resolution 62.12, urging member states to encourage that vertical programs, including disease-specific programs, are developed, integrated, and implemented in the context of integrated primary health care. And that's exactly what we want to do. And so this website will start on the 15th of November. She is now under construction. And from then onwards, we invite you to go to the website and to invite as many people to sign the statement. It will be easily to see, because we see nowadays that this is the way that healthcare is organized. And it is not only about infectious diseases. Of course, originally it was about HIV/AIDS, it was about malaria, tuberculosis, and others. But nowadays we see that the chronic conditions like COPD, hypertension, diabetes are also once more organized in a vertical disease-oriented way. And this, of course, puts trouble to people. Also because we see that in many countries, people that are in an HIV/AIDS program, they receive food grants for their children, they receive educational grants for their children. And what you see then is that, well, there is more or less a kind of inequity by disease. And we know that in certain regions, people try to have falsified certificates that they've got HIV/AIDS in order to be able to get those food grants and educational grants. And of course, yeah, for me, that's the end of humanity. If you need a disease to get access to food and to get access to education for your children, yeah, that's the end of humanity, and that's inequity by disease. And I think that this is not good for the people, that's not good for the health systems, and it is not good to make these programs sustainable, Because very often what we see is once the external donor sponsoring stops, that also the treatment of the patients stops. And I think that that's really a challenge. I still remember that once I visited a health center in a country in Africa that I won't name, and I went to the pharmacy, and there was there a stock of medication for triple therapy for HIV/AIDS for 12 months. And I was asking, well, do you have a metformin in stock in the pharmacy for diabetes? And the answer was, no, we don't have. So that makes that there is a kind of fragmentation and inequity by disease. And just in order to address this, I think we have to try to go for a new kind of approach. And we are very happy that a lot of partners want to engage in this, not only for infectious diseases, but also for the traditional so-called non-communicable diseases. And this has, of course, to do with universal health coverage, because if we have more resources in primary care, and if we have chronic conditions integrated in primary care, more people will have access to these conditions. And so this is the link that you can use to access the article where we at length have developed the description of the impact that in certain countries like Mozambique, for example, these vertical programs had on capacity building. And what you see is that very often the impact is very negative. Also, when it comes to training, there is a university in an African country where we did a study on 780 alumni of that medical faculty during the last 10 years. And we studied where those people were working. And I have to say, the good news was that 85% of the people were still in Africa. The bad news was that 50% of those people were working for one single disease, mostly in administrative functions, and so were lost for the clinical care at primary care level for the population. And I think that this is really something that's very bad. And that's why we think that if we can make that movement, that on the one hand, there is more investment for primary care, but on the other hand, that also 30% of the donor budgets to vertical programs will be invested in strengthening primary care, we can then, I think, strengthen primary care in a way that will enable more people to have access to health care and to be treated appropriately and be saved from all kinds of diseases that actually they have to suffer from because of lack of treatment and prevention. So that's my invitation to all of you. I think if we can make in Asia, in Africa, in Europe, in Latin America, and so on, this kind of action 30 by 2030. And I have to say that today I contacted Shannon Barkley from WHO Geneva, who is very much interested. So if WHO would take over this campaign, I think it could really be a game changer in the way primary care can develop in the future. So I'm open to all your questions, but thank you for the opportunity to just share with you some of these ideas. And of course, they are open for debate. And I'm very much open to answer your questions now.
Thank you very much, Jan. Appreciate that. If people have questions, feel free to put it on the chat group, and as we proceed, so we can take it up as we proceed. I think, are there any questions that people have immediately? Would they like to raise it with Jan? You can just put up your hand. Okay. Raman, if you don't mind, I think what we can do is, Raman and I will share between this of asking people to briefly introduce themselves. We hope that everyone will do it. I think this would be the easiest way. We probably would not be best off by breaking up anymore. So I suggest we just, point out people who could introduce themselves briefly and be able to speak a little bit about what they think the health system like PHC is in their country, in their sort of space, what the role of family doctors are, and possible collaborations, where they think there could be really good relationships, but what are the synergies that we could build up? And I think that your thoughts might grow as we're going along. So I'm going to start off, then Raman will call out another person, and so we'll swap over looking for people who we think would be able to start off well. So let me start with the other person from the executive, Professor Elizabeth Richie. Reggie, do you mind sharing very briefly? Let's keep it short. We'll try to finish, by the end of this hour, which is about 50 minutes away. So we keep it really short, and give us some of your thoughts on this. You don't need to be completely comprehensive. Others will share a little bit. Reggie, do you want to start? Elizabeth? I can unmute you. Okay, if Reggie is not available, can I ask for Edward? Has Edward disappeared? Chagonda. All right, Serge, would you mind, Serge Ngamba? Would you be able to share a little bit? There we are. Thank you, Serge.
Hello, good afternoon. I'm Serge Ngamba. I am a family physician originally from Cameroon and work very closely with the new Cameroon Primary Care Doctors Organization, although currently practicing in the UK. I was raising my hand there to follow on from Professor Messner's talk, because I had a question about whether there was any process for involving non-English speaking countries, particularly because Cameroon is primarily French speaking in the process 30 by 2030. I'm sure there has been some thoughts. I just wondered if any sort of documentation is already available, just because we are indeed in the process of trying to involve politicians in this mindset, and it helps to have those documents that are evidence-based and that are strongly rooted in your experience to show that the current system isn't working and which system we need to go to. If you allow me, Shabi, to just
yes, go ahead. Go ahead. I think you've got the question, and Jan can respond, and then you can go to these questions as well. Go ahead.
Je peux même vous répondre en français parce que je parle français très bien. The other people will not like that, so I will continue in English. But of course, French is not a problem at all. Your point is very well taken. And we will try to have, as soon as possible, the website in English and in French. So there will be an icon for English or French language choose on the first screen. And so there will be summaries in French, but there is no problem at all. We have in our country, in Belgium, a lot of people that are committed to this and that can excellently contribute to seminars, webinars, whatever you want in French. Le français ne pose pas de tout problème. Je suis habitué à parler ça.
Don't forget, Jan,
French is our second language in our country. So.
Don't forget the other language groups. Portuguese for Africa, I think
y podemos
Spanish.
Hablar en español también. El portugués es un poquísimo difícil.
Okay, so we'll leave you to make sure it's translations. Good.
Yeah, we make that happen. Thanks for the suggestion.
Good. Serge, go ahead, just share a little bit. I'm sure you have insights into Senegal, Cameroon, and would like to share some of the thinking you have around that. And then, Raman will ask someone to speak, and we'll just go like that. Briefly, just brief on those questions.
Primary care system in Cameroon, is that right?
Yeah, I mean, the questions are up on your screen. So the shared screen is basically just a brief introduction, your name, place, organization, and role, and what the health system or PHC particularly looks like, and what do you see as the role of family doctors, and then just if you have some thoughts around collaborating between regions.
Yes, indeed. So I think I have covered a little bit the first part there with my name and role. Just to add in terms of role, that I am the vice president of the Cameroon Primary Care Association, which we have named MedCamer, Family Medicine. And it's fairly new in Cameroon because indeed primary healthcare is still quite a broad term. And we do have a district health system, but we don't really have a clarity as to the difference between our general practitioners or possibly family physicians. And we are trying to work in sort of forming a model that would clarify that aspect of things. So the primary healthcare in Cameroon is very much a continuation or an extension of secondary healthcare in the community. and we don't have dedicated primary healthcare physicians yet, whether in training or in practice. And this is the sort of things that we are trying to change. So yeah, definitely we are keen to think that the role of family doctors in a successful health system is crucial. And it is a very good time now for us because the country is thinking about its policy for universal health coverage, which they haven't put in place yet. So politicians are quite open to suggestions, and we want to use that window as an organization to suggest that primary healthcare should be a part of the make of a health system that has a successful UHC. So we believe that some of our partners in South Asia have probably been through that process already and perhaps already succeeded in some of the steps that we are trying to take, and possible collaborative opportunities might arise with learning from their experience, so that we sort of don't stumble where they might have, and perhaps shared experience in terms of training and in terms of its health service design. And I'm sure that, for example, I was listening to India earlier, that this would probably be a place where colleagues would be keen to look at what we're doing and perhaps share the experience as well.
Great. Raman, do you want to ask someone to speak?
Yeah, may I request Dr. Parmen Prasad, Secretary Wonca South Asia from Nepal, to talk about Nepal and in general about South Asia, if you wish to.
Thank you.
Hello, everybody. I'm Dr. Praveen Prasad Gupta, Associate Professor, Department of General Practice and Emergency Medicine in BP Kwara Health Science. It's in the eastern part of Nepal. And where I am working, it's a tertiary care center in the eastern part. We have a good primary healthcare system over in Nepal. Like we have primary healthcare system, district health post, and sub health post. And most of the health posts are being run by general practitioner, and we general practitioner have different role over there. Like we are also working as an emergency physician over here. We are taking care of acute care, we are taking care of chronic care, and we are taking care of comprehensive care also in Nepal. Like we are at the same time we are giving acute care in emergency. At the same time we are dealing with the patient in outpatient department. At the same time we are dealing with the chronic patient also, and at the same time we are also dealing with obstetrics and orthopedics. Like most of the general practitioners in a rural health center, they do a surgical operation, they do cesarean, they do an operation for a fracture, open fracture, they do plasters, they do the basic orthopedic care for a patient in a rural centers. So we have, like in our family medicine, or we have in our general practice, we are a combined, like we work as a surgeon also in a periphery, and we work as a physician also. So we have both set up. In Nepal we have got different medical college. Like in eastern part of there is BP gases. In a Kathmandu there are 3 medical colleges, and in a other part also there are 1 and 2 medical colleges, where we have already incorporated our MD in general practice and emergency medicine. So our degree is known as general practice and emergency medicine. So it's incorporate everything in that, and we have to work like that. We have our specific syllabus where we have to practice about the operative procedure also, and we have to practice regarding the other chronic disease stabilization, chronic disease management, mental health management. So we work on a different sections, and we work as a different group. In a tertiary care center also we work as a faculty, we work in emergency department, and we have our own outpatient department also.
Great,
So
thank you.
that's a basic family medicine practice in Nepal. Thank you.
Thank you very much.
Thank you, Dr. Praveen. Very special type of training for family medicine in Nepal, which could be suitable for many parts of the world we are talking about, Asia, South Asia, Africa. So, Sabir, would you want me to ask next person from South
Well,
Asia.
I think from Africa, let me ask Dr. Prof. Reggie. Elizabeth, would you like? I think she's able to now. Go
Oh,
ahead, and then you can pick someone just now from the other side, from
we do.
region
Yeah.
South Asia. Yeah, go ahead. Go ahead, Elizabeth.
Hello.
Hi.
Hello. Good afternoon. Good evening. I'm Dr. Elizabeth Richie, Head of Department of Family Medicine in Free State, South Africa. We do have a district health system, which is the primary healthcare system. It's the clinics or health post. Then you have the community health centers and the district health hospitals. So that's where the family physicians are mainly concentrating. Like what the Nepal people were saying, we do basically do emergency cases in the district health system, gynae, all the operations, basic orthopedic cases, child health care, maternal care, then and also we do have community-oriented primary care where people go into the community. Prof. Shabir and I concentrate more on the community primary care because we see that we need to access more into the homes and give more health towards the people who cannot come into the hospital or to the clinics. And we also focus on giving basic chronic medications because we see patients at the clinics who really need medical care and cannot be transferred just for the chronic medications into the secondary hospitals. We also see acute patients at the outpatient department and also manage basic surgical cases. So in general, our specialty deals with all things that is needed in the primary care setting, and the training is a 4-year training where they all go through all the specialties and get basic idea of what should be done as a primary healthcare specialist. Possibility of collaboration, yes. I'm an Indian as Indian by origin, and I've also come to Wonca, South Africa, Wonca in Chennai, when you conducted it in 2014. I really would help in collaborating with you if you really need any help from me. Thank you.
Thanks, Elizabeth. Go ahead. And I think as people are coming, they can also ask clarifying questions to each other, raise points if you want questions. So over to you, Raman.
So now I would like to call Dr. Chabilal Adhikari. He is professor and head of Department of General Practice in Bhutan. So Dr. Adhikari, would you like to speak
Hello.
about Bhutan? Yes.
Yeah. Hello. Yeah, can you hear me?
Yes. Very
Yeah.
well.
Good evening to all. First of all, I would like to thank Professor Musha and Dr. Raman for giving opportunity and starting this unique collaboration between our two continents. See, this is a unique opportunity which COVID has given. Otherwise, maybe because of financial constraint, we may not have been able to attend. You see.
Sure.
Now, quickly going to the points to introduce myself, as Dr. Raman has already introduced me, I am one of the pioneer for establishing general practice program, training program in Bhutan. I was trained in Nepal and India for my master's program. And after that, I knew the limitations of our secondary healthcare system in Bhutan, where the secondary level healthcare is provided by MBBS graduates only. But I would like to say that primary healthcare in Bhutan has a firm footing, and we have a very good primary healthcare team, but we lack trained general practitioners. So that was the very reason for starting this training program in the country. So this is a 4 years master's program after MBBS. And after that, they will become the head of the primary healthcare team. And the same policy is supported by the government, the present government. So the healthcare system is built upon the integrated healthcare system. It is with primary care level, secondary healthcare level, and tertiary care level. All healthcare facilities provide free service. There is no private practice in Bhutan. Since this is a small nation and a small population, it is still possible for the government to provide free healthcare services. So patients do not have to pay for the healthcare services. So their primary healthcare to referral to secondary healthcare to the tertiary level, even the referral system is provided by the government. We provide ambulances, we provide helicopter services for real emergencies, for fast evacuations. And but at the primary healthcare level, we have seen in this COVID time also, Bhutan has not seen local community spread so far. Whatever cases we have, around 330, is all we picked up from the quarantine facility, from the Bhutanese who are living outside and coming back to Bhutan. So there is no community transmission. So this shows that our primary healthcare is very strong and it is tested at this moment. Now, new developments that are taking place is we want to add trained general practitioners in the primary healthcare team. Just now, at present, they are provided by the team leader is the MBBS graduates, but we would like to replace them with the trained general practitioners. The second development is we are giving, our services are all integrated, as Professor Jain and Professor Musa, you were highlighting that still in Africa, there are some countries which have vertical systems, but in ours is all integrated. And now we are giving more focus on NCDs. As said, we have a double burden of diseases, but then NCDs are taking over that now. So new developments are, I'm providing some assistance to the ministry on developing patient's handbook, which has patient's information about the NCDs. And also there is a note for follow-up visits. Since this is free of cost, they will be required to visit hospital every monthly or 3 monthly with that handbook. And that will provide a comprehensive advocacy about their diseases. So these are few new developments that are taking place. And now regarding possible collaborations, I think building leadership in our new residents is one area which because we are very few trained general practitioners, we are at the very senior level, we may exit the system in few years time. So we need to develop new leadership in our young doctors who have taken up this GP. So right now we have the final batch, Dr. Kinle Bhuti. She is the representative for Spice Route Movement from Bhutan. And we would like to advocate this program, GP program, so that more and more doctors take up this program, and then we will be able to man all those primary healthcare facilities with trained general practitioners. Thank you, Dr. Musa and Dr. Raman.
Thank you. Thanks. Really appreciate those comments and that insight. I'll ask Frikkie Kellerman to just share a little bit. Frikkie's more in a training space, but I think that's quite the interest by many of the people in this meeting. Frikkie, would you mind just sharing a little bit about yourself? And your thoughts. Yep. Thanks, Frikkie.
Thank you. I feel privileged to join your meeting today. I did my basic training in South Africa, and in the rural area was involved with community health for 10 years, as well as training clinical nurse practitioners. And that was the time that I saw that the backbone of primary healthcare is actually in the nurse practitioners as well as the community health workers. So I have always seen family physician not as an entity in its own, but linked with the nurse practitioners, community health workers, community-based setting. And I have seen that that is a key role in trying to make a difference in the primary care level. I've taken a journey on different things, but for the last 8 years, I'm involved with training of family physicians here in India at the CMC, the Christian Medical College in Vellore. And at the department here, we use distance education, blended learning, and they've trained approximately 4,000 doctors now in family medicine. There is also a program for residential family medicine training here. And just in the last couple of years, I've seen a tremendous growth and blossoming of family medicine in India. Dr. Raman is here. He can say much more than I do, but I've seen there is really the tide turning. But the problem is still, though on paper, the primary health care system is excellent. In practice, especially in the decentralized areas, the functioning is not optimal at all. And most of the family physicians that complete the training here work in either hospitals or private facility, not in the primary health care decentralized setting. At the moment, if I'm correct, we don't have any family physician posts in the government health sector, but decisions has been made to release posts, and we think that will be a tremendous boost for in the right direction. If family physician posts will be at the primary healthcare centers and the community health centers, so that they can work with community health officers and the village health workers, I have hope that that can happen, but we are not there yet. But in the meantime, training is going on and there's collaboration on different levels and different programs are developing. And because I've been involved with training of clinical nurse practitioners and family physicians in Africa and now in India, my heart just feels we have to work together. And from my angle, at least on the area of training, sharing resources, sharing ideas, sharing expertise. And I hear from what you say, others are working on a completely different level, but this is the angle I come from. And at the moment, I feel very privileged to be involved with it. I think that is all I'll say for now. Thank you, Dr. Shabir.
Thank you
I think, Dr.
very
Shabir,
much. Yeah.
you worked with Dr. Claire van Deventer?
Yes.
Yeah, I worked with her for 10 years.
All right. Wonderful.
And that is where my journey started. Yeah.
Good, good.
But
Well,
very happy to.
Yes, we're really fortunate you having, both spaces that you are working in, and that's a huge insights that you'd have. Just a quick question before Raman points someone else out is, did you, you basically said that in Africa, there's a lot more teamwork going on. In India, as you've experienced now, and you said that doctors are not located in that primary care ambulatory setting. They're more at hospitals or in sort of the private sector. How would you, where is the nurse clinical practitioner there? Is that a feature? Maybe others can speak to it. And what is your perspective about the sort of that mix and us and your thoughts of how we could actually grow together, or lessons to learn from each other?
Thank you. Very briefly, I try not to compare, but just put myself fully where I am. So I try not to speak of this or that place when we work here, and yet we cross-pollinate and learn from one another and from mutual experiences. Having said that, I was struck by the fact that, if I'm correct, approximately 70% of health services in South Africa are in the public sector. Approximately 70%, Dr. Raman can correct me, in India is in the private health sector. And so you have the huge problem of medical debts linked to that. Now, that in itself is a major thing. And in the South African context, you know that in the primary care setting, it's nurse-run, nurse-led. Family physicians are only coming in now in terms of developing the district health models better. But in India, we don't have clinical nurse practitioners well recognized. There has been efforts to initiate the training. I know of 2 or 3 places, but it was discontinued. At the moment, there are thoughts of restarting it, but not so. The bigger move in India now, I think, and I say again, please, Dr. Raman, correct me, is the focus on community health officers that work in the primary healthcare settings, that they can be upskilled to be the main person to link the home-based work and village health work with the primary care and secondary care setting, with the family physician coming in as a facilitator, trainer, supporter on the primary care level. So that is the difference. I hope I explained it sufficiently in this short time.
No, thank you. I'm sure that the next person, or Raman, will share with us what the community health officer is as a qualification, but thank you. Raman?
Thank you.
Thank you. Briefly, a few seconds to respond. There is, I mean, for placing family physicians, government in principle has agreed to post them at community health centers, and this decision has been taken to revise our Indian public health standards, but it is not, officially published yet. And secondly, yes, the focus in community health officers and also on nurse practitioners, but the nurse practitioners issue is of legislation and kind of, making them enabling, practicing independently is an issue of content, there is some conflict also because of the, and there is also largely from the medical community opposition from Indian medical associations and all on and upskilling of community health workers for clinical work. So, but largely the new health and wellness center would be manned by the community health officers, the 200,000 which the government is envisaging. Family medicine specialists would be posted at community health center, not now at the primary health centers. They would be posted, manned by the medical officers, the MBBS doctors. So, it's coming to places, but still there is, a lot of tension within to, to streamline it. So, we move next, and we will
Raman,
discuss
before you go
more.
to the
And,
next person, I think Elizabeth asked the question, what is the qualification of that community health officer? Is it an MBS, MEBS, or is it a sort of, what is the qualification?
It's a new training program after high school. It's not a full, practitioner's qualification.
How long is the training
So it's
for?
like, if I'm right, it is for 2 years. I'm not sure because, I've been listening about it, but I haven't looked at it in details.
Right.
But it is a non-licensed qualification, and most of the state governments have started it across India.
Okay. Okay, you can go to the next person and go ahead.
Yeah, sure. So we will try to cover most countries in our region. So may I request now Dr. Hina Javed to talk about a bit about Pakistan from this, questions, discussion points. Dr. Hina.
Hello there. Thank you for giving me the opportunity to talk. It's been an excellent forum. I've been listening to all the presenters. Sorry. My name is Dr. Hina Javed. I work as an assistant professor in University of Health Sciences in Lahore. The primary healthcare system in Pakistan is not well developed. I would say we are still in the process of getting there. A lot of things have happened, and I can talk about the region of Punjab, the province of Punjab, where I'm based. We are collaborating with a lot of people. We need a lot of advocacy, networking, lobbying with the bureaucracy, the politicians. And we've seen mobilization happening, particularly from this year. The Pakistani diaspora based in USA, UK, Europe, Australia, and other countries, they are chipping in and helping us. So we are making noises in a lot of quarters. We are working towards things like research, training, particularly at the grassroots level. It will take a while, a long time, because as I said, primary healthcare is in infancy in Pakistan at the moment. So it will take us a while, but a lot of help is being offered inland and from abroad as well. Moving on to the next question, I think I've covered most. The role of family doctors has been discussed quite a lot already, and I think it's the cornerstone. It's the first line of defense for any community, because we have got too many specialists, same as many other South Asian countries and probably the African countries as well. So we need to build up a ratio where we gradually raise our game and increase our numbers, and particularly focus on the training of the doctors based in primary healthcare centers to reduce the burden of communicable diseases. Thank you.
Well, thank you very much. Can I ask a quick question? Is the primary health care center a sort of an ambulatory care center in Pakistan? And is it manned by just MBBS, or is there clinicians, community health workers? Who are the other clinical team? And
Okay.
and how does that function as a team? I just want to see, if there's overlap with our experiences.
All right, okay. Well, some of the basic health units, we call them BHU for short, they are 24/7. They have got a doctor available, which is an MBBS. That's the primary qualification. And along with a dietitian, a lady health worker, a person trained for vaccination and stuff. And those that are running 24/7, they do offer maternity, antenatal care services, things like assistance with breastfeeding and all the guidance and the immunization of pregnant females as well. Deliveries do take place in some of the centers, but not all. But what I have now, since I've started engaging with the government, my aim is to bring more trained doctors. Like one of our colleagues from Bhutan also said that they are focusing on trained doctors in primary healthcare because they're just MBBS and they've done 1 year of house job. They haven't had any formal training in terms of communication skills, consultation skills, managing the condition, where the limitation of primary healthcare doctor finishes and the boundaries of specialty begins, how to be competent and safe. I've been trained in the UK in the NHS. So what I try to do is bring back that experience into the country. It's not one of the easiest jobs, and I'm faced with plenty of challenges, which I don't want to go into the details of. But as I said, we have made noises, and I can hear some things happening. The recent development is we have been asked, our university's faculty has been asked to get involved in South Punjab training of medical officers based in the primary healthcare system. And we are collaborating with other major institutions in south of Pakistan, Karachi, Aga Khan, the Indus Hospital. They've got plenty of resources and they've worked in a very organized way. So we are collaborating with a lot of institutions, and hopefully we'll be seeing change in near future, inshallah.
Sure. Thanks. Perhaps, Yaman, I could just ask Dr. Kwame, who is the AfriOne chair. He's from Ghana, to just share some few thoughts.
All right, thank you very much, Prof. Shabir. So with Ghana, family medicine is still at the early stage. It's still quite at the infancy stage. So for us, the distinction has always been between who is called a family physician and who is called a general practitioner within our setting. So that distinction is made based on whether the person has had postgraduate training in family medicine or that the person is post-medical school trained. Then the person is classified as a GP. But we all play our roles at the primary care setting. What we are trying to do now is to develop the modular training system so that for general practitioners who have been at the district level working for several years, they can enroll into the postgraduate training and get certification as family doctors. And then they'll be part of training as well, up to the fellowship level. For the Ghanaian system, in terms of primary healthcare, the basic component of the primary healthcare system is the CHIPS compound. So these are small health centers that have been set up in various communities, especially in the villages, in the under-resourced areas. And these community health centers are manned by community health nurses. Usually we don't have a doctor or a nurse at the diploma level manning these centers. And the community health nurses are certified nurses. Usually they don't have diploma or degree, but they man these centers. And periodically they are sent to district level hospitals for refresher training some of them also work with the traditional birth as attendants to do deliveries, to provide care for emergency malaria care, diarrhea, vomiting, especially in children, before they are referred to the higher center. So the CHIPS compound first, and then you move out up to the other primary healthcare facility like the district level hospital. Then you have the secondary level, we have the tertiary level hospitals. Our primary healthcare system has been bolstered mainly by the National Health Insurance System, which is working very well. I mean, the National Health Insurance Scheme. For that, everybody who has contributed to SNIT, some deductions are made into the National Health Insurance System. So this has to do with, this is a major part of primary healthcare funding in Ghana. Also, we've included the National Health Insurance Scheme funding in VAT, that's value added tax system. So for every service provision, restaurant, if you go to a restaurant, you buy anything in a shop, you get some percentage deducted into the National Health Insurance Scheme, which is used to fund primary health care. The major challenge we have has to do with infrastructure in terms of IT. So for us, most of the hospitals are run, they are paper-based. So we use folders, we use written notes and all that. And that makes it difficult for us to link the various.
You okay, Kwame? So you're breaking up slightly, Kwame. All right, sorry, Kwame, it seems like you've been cut off. Perhaps we give you a few seconds.
Facilities. Patients will show up and it's difficult to be able to identify. Hello.
Hello, sorry, Kwame, I think you were cut off for a few seconds, but
okay.
Yeah.
Yes. So I got to the point where I was talking about the creating an infrastructure of electronic medical record system, which can link all the facilities so that from the basic primary care level to the tertiary level, those records will be made accessible, and that will make it easy for patients' medical records to be retrieved. So generally, this is what the experience I can share in the Ghanaian perspective. Unless maybe there's a follow-up question or anything else, then I can provide that.
Yes.
Thank you.
Good, great to do that. Raman, anyone with a question, or if you have a question for Kwame to clarify anything? No? Okay. You can...
Yeah, but what I also want to add would be how well organized we are. So we have the Society of Family Physicians of Ghana that has all the family physicians in Ghana who are registered. And currently we are more than 150 trained family physicians. But in terms of general practice or those in private practice, then we have the Private Practitioners Association. What we are trying to do now is to merge the two so that those in private practice who are quote unquote like general practitioners can also access some of the programs that the SOFPOC, which is the Society of Family Physicians of Ghana, organize. And we can also have a way by which some of them can be certified to be family doctors. Yes. So that's just the addition I wanted to make. Thank you very much.
No, thank you very much. Appreciate that. Over to you, Raman, and we'll have one more. And after Raman, we'll just try and summarize some of the learnings and see how we take this forward.
So we have two more countries to discuss from
Sure.
South
Go ahead.
Asia.
You can do them both, and then we can talk over them.
Briefly, I would ask Dr. Zakir Rahman to speak from the Bangladesh perspective, and then we call Dr. Sankha, who is also Spice Route Chair.
All right.
To briefly talk about Sri Lanka and Spice Route.
No problem. Good. Go ahead.
Hello.
Yes, we can hear you. Go ahead, Zakir.
Yeah, this is Zakir Rahman. And we have so many similarities in South Asia region and Wonca Africa region. So the timely initiative taken by Dr. Rahman and Dr. Sabir Musa. Thanks. This is very important to improve ourselves. And it will be a good collaborative option to be open. I hope so. This is
Yep.
Zakir Rahman, and I am working in Bangladesh. And actually, we are hosting 17th Wonca Royal Health Conference, and we already finished opening 3 days, and 13 webinar going on, and 21st February our closing ceremony. Possibly this is the longest World Royal Health Conference. And the family medicine and primary care front of view, we have a small tier that is community clinic that is for 6,000 people in my country, and it is in working in urban and rural areas, but they are not doctors. The head of community clinic is trained health worker, and sometimes they are sub-assistant community medical officer. They have a designated university degree, but not doctor. And they refer the next level, they are MBBS doctor. And ultimately in Upazila Health Center, well-equipped operation theater with every sorts of operations and complex things they are handled. But so many ways to go for proper healthcare in my country. We have to work more. And very recently, we got a message from Honorable President, People's Republic of Bangladesh. So he's the policymaker, and we are planning to give some agenda to our policymaker, as well as we are planning to Prime Minister after finishing our conference. And the proceedings is uh, here primary care is up to certain limit is free, but you have to buy it because more than 100,000 doctors, most of them are working in private facilities, private hospital or corporate hospital, or simply GP, general physician. So we have to work not only in government, we need to incorporate all these private doctors, and we are going to PPP, that is public private partnership. So hope it will works better. And currently we have Bangladesh College of General Practitioners, those who are already 30th batch of fellowship in general practice, and Bangladesh Academy of Family Physician giving the diploma of family medicine, and primary care royal health. I belongs to this group as well. Fortunately, all the three family medicine organization, I have the opportunity to work with them, and I am a teacher as well as. So actually we need to overcome more of the things, and collaboration things. Yes, we have so many options to collaborate, and primarily we can go for advocacy between the region, and we can go for primary care research, and not so much money needed for primary care research. We can do it in our chamber as well. We can give share some data, and we can publish it jointly. May I think Raymond would be right person to handle it. So hope for collaboration is very important, and we'll give the message to the around the globe. So such things are we are doing, and we are going to be that like that. So I think once we touch the universal health coverage and health for all. So this is now from my side. Hope for the best.
Thank you.
Thank you, Dr. Zakir, and may I call now Dr. Sankha for very briefly about Sri Lanka. We know Sri Lanka, it's much better than rest of the South Asia. And may I also request Sabir, because we are not many people in this group, and I see few odd names, we can ask them to introduce themselves.
Yes, I think so.
A couple of sentences on this collaboration, at least.
Yeah. So let's get everyone to say something. Yeah.
Yeah, sure. Dr. Sankha.
Thank you, Raman. Thank you, Professor Shabir and Raman, for this collaboration and this dialogue. If I talk about Sri Lanka, actually Sri Lanka has a very good primary care system, but mainly this is regarding the preventive care, primary preventive care. Our public health system is very, very strong. When you take the primary ambulatory care, we have few lapses yet. We have about 1,000 primary care institutions in Sri Lanka, spread all over the country. Two types, divisional hospitals and primary medical care units. The difference is divisional hospitals have some beds, so it has night stay facility. But all the other primary care units operates in the same manner, like the outpatient departments, emergency care, NCD screening and NCD treatments, then immunization, maternity and child health, etc., and also the family planning, mainly. And when you take this is the government sector totally. Sri Lanka has a free health service and free education, so the government sector is so strong. When you take the family medicine, we have a general practice system, which is actually totally private sector. General practitioners complement the government sector because most of the government medical officers practice as general practitioners in the evening hours. So this is a complementary system. But the problem we have is most of these people just have the MBBS, even though they are told general practitioners. So usually most of the trained general practitioners do not call themselves general practitioners. They call themselves family physicians because of this problem. So at this moment, the Sri Lanka has the backup from the World Bank for reorganization in primary health care, and we are mainly focusing on this sector, especially to train the general practitioners and have a trained general practitioner service. So the College of General Practitioner also is involved in this, and now for a long time we have the MCGP course. College offers the MCGP course to get down a qualified general practitioner. Government, the Postgraduate Institute of Medicine, has diploma in family medicine and the MD in family medicine. So MD when you get the MD in family medicine, the consultant family physicians or the specialist family physicians are produced and they work in their divisional hospitals. So this is the system, and mainly the problem is with the practitioners or the medical officers who practice in after hours without a qualification. So that's the thing we would like to rectify. So that's about the primary healthcare system in Sri Lanka. If I briefly talk about the spice route, I can see a few of my colleagues in this forum. The spice route, just like the other young doctors movement, is actively involved in many things. But actually, for the last 2 years, I'm really happy. All the countries are really active. All the leaders are really active. The spice route leaders in all the countries. Currently, our main targets are training, medical education, research, and also fellowship. I think fellowship is also very important. So monthly we have our leaders meetings, and monthly now we have webinars handled by, and actually they are handled by the individual countries, but for the spice route as the region. I think as we are running out of short of time, I think that's enough for the moment. Thank you very much. I think this collaboration would be a great one because we share many similarities as Africa and South Asia. So we can collaborate in many things, not only in medical education, in research, sharing best practices, learning from our own countries and practices. So I think this is a great initiative. So let's go forward with this. Thank you very much.
No, thank you. Thank you. Raman, shall we start at the bottom with Sunita and, just if you could just share, shall we start at the bottom and just make sure we go through everybody in the list? If you could just introduce yourself briefly and any
May
thoughts.
I request Dr. Sunita, if you are present?
Yep.
Introduce yourself. Yeah, and say a few things about what do you think about this idea of collaboration on.
Any thoughts?
Good evening to one and all. This collaboration, I guess, it's a very welcoming idea. So thanks to Dr. Musa and Dr. Raman. So to think about it, I am actually practicing in a corporate hospital. I head the Department of Family Medicine and Preventive and Promotive Services for the hospital. So, being in a corporate hospital, as Dr. Raman has already said, in India, we do have different ways of, even in private practice, there are different ways a family physician practices. So in that way, I guess, like, mainly for the advocacy and the research, in my personal opinion, we need to have a strong collaboration, because we need to get to learn from each other, and also to pass it on to the policy makers, so which can in future help even the young doctors to get interested in family medicine, and also even the public to become more aware.
Hmm.
Because even in India, we do have this overlap between the general practitioners and the family physicians, because most of, it's not just general practitioners. When I say, like, it's MBBS doctors, there are other specialists. For example, it could be an ENT specialist, or some other specialist. They also say that I am an ENT specialist and also a general practitioner. So there is lots of confusion. So I guess it's time to have a strong collaboration and come up with the advocacy. And being in an academic hospital, I mean, where we do have training, so research is very important, and especially for us as family physicians, because not many people are aware about family physicians, even in a city like, I am in a metropolitan city in South India. There are many doctors who are not aware of family medicine still. So we are making our own programs, but still that confusion between family physician and general practitioner, it still exists. So this is in brief. So thanks for giving
Thank
the
you.
opportunity.
Thank you. I'm calling people from the list. So
Go ahead.
now we have Dr. Thula Gupta from Nepal. Dr. Thula, are you there? Would like to say a few words? I don't hear. So may I? Yes,
There
Dr.
he
Thula,
is.
you there.
Go ahead.
Just briefly, I request everyone to be very,
Hello
very brief.
everyone.
Introduce yourself and what you think of this collaboration.
Hello everyone. I'm Thula from Nepal. I'm working as a general practitioner in a very rural part of Nepal. As Dr. Parminder has already described about the system we have in Nepal, so I'm not going into detail. So that's the same thing going on in a primary healthcare system in Nepal where I'm working. It's like I'm a single general practitioner over there, and I have two medical officers. With the help of two medical officers and me, like we are giving care in primary health care, and we are doing all kind of things like emergency surgeries and chronic care and mental health care. Thank you.
Thank you, Dr. Thula. May I now request Dr. Resmi Kamal from India? Briefly introduce yourself and what you think of this collaboration. Very briefly, please.
Good evening, all. Thank you, Dr. Raman. Actually, this is a good idea of having a collaboration between Africa and South Asia, just to see, initially we have to see what are the similarities and differences that we can address first. So I'm Dr. Rishmi from Kerala, which is a southern state of India. And I work in an academic hospital which trains for the 3-year residency program in family medicine. So my role is mostly academic there, and since it is a mission hospital, a Christian mission hospital, semi-corporate you can call it. So the role of family physician there is different from in the community, but still we have a lot to do in the sense we are having our own smaller hospitals, attached small hospitals where we go and work. That is one thing. And in the tertiary hospital itself, I've realized that there is a role for family medicine for a first coming patient who's coming for the first time to the hospital, to direct that patient mostly in a tertiary hospital. You know how it happens in India. You can shop for how many doctors you want. So there also family medicine has a role, but my major role is in training the DNB family medicine residents, which is a 3-year residency program in India. The health system in Kerala is mainly like in any other state in India, with a small difference in the sense that there is a lot of appreciation about the Kerala model of primary health care. It is mainly because the government has so many programs and there is a strict, not 100%, but a better adherence to the protocols in government system also. So we have a better primary healthcare system running, and we are moving in the direction of incorporating family medicine into that system. Actually, now it has not come into force, but most of the primary health centers have been in principle converted to family health centers, where they stress upon the wholesome care or a holistic care of the person and the family. So in due course, we have submitted representations to the government so that there will be family medicine trained qualified people appointed in these primary health centers, which are going to be family health centers, so that there will be a better integration of the of our specialty into the public health system. That is one thing that we are trying for now.
Thank
The
you,
possible
Dr.
collaborations.
We are short of time.
Yeah.
So I request now Dr. Srinivas to very briefly introduce yourself and say a few words. Dr. Srinivas.
Thank you.
Hello.
Yes.
Good evening, everybody. Thank you very much for giving me this opportunity. The coordination between the two countries, two regions rather, or the two continents is very good idea. And in the southern hemisphere, we belong to the southern hemisphere, and we are the ones ruled by the Western industrialist powers. Most of our countries, they got independence during the 40s of the last century. It's better we add Latin America also, because Latin American countries also, they are also similar to our Africa, Asian countries. So it's better, I feel, because in concerned various health indices, level of the economic development, belonging to the third world countries, developing countries, and if there is a coordination, definitely it will be a good results will be there, because there is an online movement was there, but it has receded due to various reasons. But in the health sector, if we come forward and if we organize and if we build a coordination, cooperation, that will be very timely, and it will help the people underprivileged of these our continents, especially these Africa, Asian, and Latin American countries. That is my opinion.
True.
Thank you very much for giving me this opportunity.
Thank you.
I don't see any other person from South Asia. Shabir, would you like to call people?
I think I'll just go through the list. I think James Munguiko, I think if you would like to share, then Fanny, Colin, and I think we'll be done. James Munguiko, if you can share. Otherwise, Fanny, if you can unmute yourself and then share.
Bonjour, moi c'est le docteur Fanny.
Good,
Je viens
Fanny.
du Cameroun et je suis médecin généraliste. Et il y a une petite nuance entre médecin de famille et médecin généraliste, mais ici chez nous, les médecins généralistes, c'est ceux qui ont terminé les études, mais qui n'ont pas encore fait une certaine spécialisation. Donc, ici au Cameroun, on n'a pas encore de médecin de famille à proprement parler. Les soins de santé primaires sont octroyés par ce qu'on appelle les districts de santé. Comme le docteur Serge Ngamba l'a dit tout à l'heure, ce sont les districts de santé qui sont supposés offrir les soins de santé primaires aux populations. Et cela se fait beaucoup plus avec l'aide des agents de santé communautaires qui sont ces personnes que nous avons prises dans la communauté et que nous avons capacité pour pouvoir offrir certains soins en santé. Donc, comme Dr Serge l'a encore dit, le Cameroun est dans l'optique d'aller vers la couverture santé universelle et nous pensons donc que les médecins de famille pourraient être d'un grand support pour pouvoir se déplacer vers cette couverture santé universelle. Donc, nous espérons, avec le Dr Serge Ngamba et quelques-uns, nous sommes en train de vouloir mettre sur pied une formation qu'on pourrait offrir aux médecins généralistes ici pour pouvoir se perfectionner en soins pour être des médecins de famille. Et nous sommes dans une démarche que nous avons entreprise depuis quelque temps. Donc, on espère du partenariat gagner quelque chose, pouvoir obtenir soit des modules de formation, un support ou alors un accompagnement pour pouvoir mettre cela en place. Donc, c'est ce que je pouvais partager. Merci encore d'avoir organisé cette session et je suis contente.
Thank you very much, Fanny. Can I ask Jan, if you don't mind, just briefly interpreting for us? I'm not sure that everybody understood. Jan? Fanny, if you can, but briefly English.
Yes, I can.
Yes,
Briefly,
thanks, Jan.
in Cameroon,
Thank you.
actually, the general practitioner is somebody who just finished undergraduate training. Now they are looking for establishing a postgraduate training in family medicine, because until now, those doctors were not yet involved in the primary care, which was done by kind of medical assistant, that is somebody with specific training, as it has been in most of the French-speaking countries in Africa. So they are really looking now for good materials that may help to construct a strong curriculum for postgraduate training, so that those people that finished undergraduate training can be trained specifically with the needed competencies, knowledge and skills to become family doctors and then be included in the primary care system. So that's really an appeal to all of us to help them. And I think we have a lot of expertise. There is a lot of expertise in Africa and in Southeast Asia with all of you in how we can work. Think about using the International Classification of Primary Care, using communication training modules, learning about community-oriented primary care. So I think that all this could be very helpful for Cameroon. I had the privilege to be there, I think something like 20 years ago, and to teach to the family doctors in training, in undergraduate training then about family medicine. So it comes with huge opportunities, and it can also be the linking pin between the French-speaking and the English-speaking world in Africa, which is of utmost importance to really give the movement, give momentum to the movement of developing family medicine, médecine de famille in Africa.
No, thank you very much, Jan, and thank you very much, Fanny. We really appreciate you being in this meeting. I hope you've been able to understand the English, and we want to actually make sure in future we try to accommodate language groups, so French and Portuguese. So thank you very much for being here and sharing your thoughts. Let's go to Colin Goldberg and James Munguiko, and then we can just briefly wrap up in 2 minutes and end there. Thank you very much. And I'm sorry we've gone longer, but I think this is really very useful to have more time allocated. But thank you very much for joining us. Who's able to speak? Colin, thank you very much, Colin.
I do a lot of research and so on, and always looking at different things and also looking at methods of records and all that.
Yes. Where are you based, Colin, if you don't mind just sharing?
No, I'm based in Cape Town.
Cape Town, right. A family physician in private sector?
No. I'm in ambulance field.
Right, great. So your thoughts on this meeting?
It's very important to collaborate worldwide.
Right.
And what's also important is to have an electronic record system that patients can go anywhere in the country, in the city, in the world if they need medical care, and everybody has access to the same records.
True, very much. So I think there's plenty of opportunity to collaborate, thinking around the strengths and weaknesses. So thank you very much, Colin, for that thought. And then I think the last person has left us, I think. So
Can I just
yes,
add
go
another
ahead,
thing?
Colin.
You have a problem that patients hop from one practitioner to another for various reasons. So to give them the freedom to go to wherever they need for their healthcare, that everybody can access to the records. So there needs to be a paradigm shift in the way one looks at the confidentiality of records.
Yeah, true.
So
So
what
we
is
need,
restricted?
there's an opportunity to explore that kind of idea, you know, between the continents. Raman, perhaps you want to say a few concluding remarks. I can conclude and just share a way forward, and we can finish.
I think from the discussion, what emerges that there's a lot of interest in collaboration and among all our member organizations, countries, and we understand the purpose of it, you know, because we are very similar, or you know, and we also want to know about the dissimilarities. So of course, in all areas of research, advocacy, we can, in my understanding, we can do, as we previously discussed, a paper or a call or some joint statement coming out of this. We could describe briefly experiences which we discussed just now.
Yes.
Picking a transcript of it if possible.
Yeah.
And then we communicate with the people who participated today. In due course, and keep them connected through future meetings, conferences, or possible events.
That's right.
Focus events on research, academics, advocacy, or training.
Yeah. No, thank you. I think I share exactly that same sentiment. I think this, all the stuff that you've put out here has been really useful thoughts that Raman and I could put together in an article. I think that'll be useful to just put it out, put more some of the detail, make it a document that would be useful to reference. And I think what Raman suggests as well of finding a way. This recording will be available on, on the website, Wonca Africa, and available to South Asia as well. We will try to look at meetings going forward on a bit more of a focused basis, looking at some of the issues that Raman has just raised. So, ditto, Raman, I think it's exactly the thinking that I share as well. I think there's a great deal of synergies possible. I think the document we try to put together would try to help that collaboration forward and look at a plan, on paper to take it forward. So, with that, Raman, I think we can close this meeting on a very successful note. It's been very, really useful having, all the people that have been here. Appreciate your time and energy spent. I think that, thank you all. I just want to share with you quickly a song as well that, also was interesting. So you can just watch it as we leave. So let me just quickly go to it. If you go to the menti.com, so let me just quickly go there quicker. Sorry.
And also possibly our support to 30 by 2030 for both reasons.
Yes, I think that we should circulate the information that Jan has provided. So we'll certainly put it out into the public domain and take it from there. So let me just find a way to play that last song as we all leave. So thank you. Sorry, my internet's a little slow. Right.
Money fall on you, banana fall on you, Prada fall on you, cause I'm in love with you, eh? Money fall on you, banana fall on you, paparazzi follow you, cause I'm in love with you, eh? Are you done talking? Tell me baby, are you done talking, eh? Are you done talking? Tell me baby, are you done talking, yeah? Are you done talking? Tell me, baby, are you done talking, yeah? Are you done talking, ay, ay? Are you done talking, yeah, ay, ay? I don't wanna be a player no more. I don't wanna be a player no more. Cause tu जाने मैं तेरी हूँ, बस तुझी से हूँ, सबसे ये कह दूँ. Plus tu जाने मैं तेरी हूँ, बस तुझी से हूँ, सबसे ये कह दूँ. Oh, oh, money follow you, banana follow you, brother follow you. Cause I'm in love with you, eh? Money follow you, banana follow you, paparazzi follow you. Cause I'm in love with you. If I offend you, if I offend you, because sorry, oh baby, take I do. Sorry, oh baby, take I do. I'm in love with you, and I'm in love with you, baby. Nothing of it will change, more. Nothing of it will change, more. If I talk, they go say I did talk. Tell me why didn't they use Panadol for our headache, yeah? How I go chopping my baby, no chop. They want to spoil our market, yeah. I don't wanna be a player no more. I don't wanna be a player no more. Cause tu जाने मैं तेरी हूँ, बस तुझी से हूँ, सबसे ये कह दूँ. Plus tu जाने मैं तेरी हूँ, बस तुझी से हूँ, सबसे ये कह दूँ. Oh, oh, money follow you, banana follow you, brother follow you. Cause I'm in love with you, eh? Money follow you, banana follow you, paparazzi follow you. Cause I'm in love with you. If I offend you, if I offend you, because sorry, oh baby, take I do. Sorry, oh baby, take I do. I'm in love with you, and I'm in love with you, baby. Nothing of it will change, more. Nothing of it will change, more. Money follow you, banana follow you, brother follow you. Cause I'm in love with you, babe.
That was great, Sabir. Our cultural similarities and mix of what we are.
That's true. Fusion. So I think that says that there's lots of possibilities with us as two continents, two regions, fusing the work that we do, fusing the thinking that we do. So thank you all very much. Raman, thank you very much for facilitating
Thank you,
this.
Sabir. Thank you, everyone.
And we
Bye-bye.
really appreciate it. Goodbye. Enjoy your evening. Take care.